Hello, my name's Claire Harrison. I'm a consultant haematologist working in London in the UK. And I would like to talk about the data that we presented at EHA 2021 concerning overall and progression-free survival with fedratinib, a recently approved JAK2 inhibitor. Now, fedratinib was developed shortly after the approval of ruxolitinib and went through a phase 3 trial called JAKARTA, where 2 doses of fedratinib, and we'll just be focusing on 400 milligrams today, were compared with placebo. 400 milligrams is the focus because this is the approved dose. There was also a second study called JAKARTA 2, which was a phase 2 study, non-randomized, for patients second line after ruxolitinib. Now, these trials reported quite some time ago and have ultimately led, after a period of a clinical hold because of concerns about Wernicke's encephalopathy, to the approval of fedratinib for both first and second line treatment of patients with myelofibrosis, focusing on symptoms and splenomegaly. But as we know, for our patients treated with ruxolitinib, there is data concerning progression-free and overall survival benefit with this medication. So the question has remained open for fedratinib in this respect. So in the analysis we present at EHA, we looked at progression-free survival according to IWG MRT criteria and overall survival. In the first-line study, progression-free survival was statistically significantly longer, 5.7 months actually, longer for the fedratinib 400 milligram arm versus placebo. And that was significant in an intent to treat analysis, despite the fact that the majority of patients on the placebo arm crossed over at 6 months to receive fedratinib. The majority of patients, however, stopped receiving treatment at some point after 18 to 24 months because of the clinical hold, and therefore there's not any longer follow-up for progression-free survival. Concerning overall survival in the frontline setting, there's no clear evidence of benefit, but the survival rates at 1 year was 92%. And not superior nor inferior to placebo, and especially considering that we would expect overall survival to be good for these patients, and 3/4 of the placebo-controlled patients crossed over, as I already mentioned, to fedratinib. This is reassuring data. Now, the patients that we know are really struggling in terms of their progression and overall survival are the second-line patients. And here, progression-free survival was 13.3 months, with 64% of patients still being followed at the time of clinical hold, with a median follow-up of 5.6 months. Concerning overall survival for these patients, overall survival second line was not reached, with 1 year and 18-month overall survival rates at 84% and 67% respectively. So I think this data is really important when it comes to thinking about how we might use fedratinib and whether it does or does not have benefit for patients in terms of progression-free and overall survival. For first-line patients, considering we were comparing to placebo, the data is quite clear. And in the second-line setting, I just want to draw your attention to a recent publication from John Mascarenhas, where in the post-Rux group of patients, median progression-free survival was only 6 months versus 13 for JAKARTA 2. And overall survival was 11 months in the second-line setting in the real-world data and not reached in JAKARTA 2. And if you looked at 1 year overall survival rate, it was 47% real-world and 84% for JAKARTA 2 patients. So these data is certainly favourable and reassuring. Fedratinib is becoming available for clinical practice, and there are ongoing studies, the so-called Freedom 1 and Freedom 2 trials, which will give us clearly more information. And just one last point to make: when using fedratinib, it is important to monitor for thiamine levels. Even though the clinical hold has been lifted, it's really important to check thiamine levels for your patients, consider supplementation, and manage gastrointestinal toxicity. Thanks very much.